All right, let's get into our discussion. Joining me now in studio is Dr. Simon Kigondu, Chairman of the Kenya Obstetrical and Gynecological Society Central Branch. Next to him is Dr. Emily Njuguna, a pediatrician, the African Regional Technical Advisor for Maternal Child Health and Development at PATH. And next to her is Patrick Toe, a neonatal nurse at Kenyatta National Hospital and a non-executive director of the Council of International Neonatal Nurses. Quite a mouthful. Thank you all for joining me this evening. Dr. Kigondu, let me begin with you just to get an understanding of how a preterm birth happens in the first place.
Yeah, so thank you very much. Preterm prevention is better than cure. So we have said the obstetrician and gynecologist and the midwives comes to prevent preterm because we do not want, as she will describe, the problem. So you have to identify some of the risk factors like age. If you start delivering when you're too young, then there's the risk of preterm delivery. Spacing, if you have too many babies near each other, then there's a risk of preterm. When the uterus is too big, over-distended, such as multiple pregnancies, twins, and there's a lot of people want some medicine to get twins nowadays, it's risky to get preterm. Infections, such as urinary tract infections, malaria, HIV, and the others also cause fever, can cause preterm delivery. Nutrition, when you are low, underweight, and when you have other illnesses that are chronic, like diabetes, blood pressure. And when the cervix, a very common one, is weak, what is called cervical incompetence, the baby becomes a bit heavy and comes out before time. And there are also other occasionally related maternal psychological problems. So it's good to get the mental health aspect early. And one that we need to try to prevent, where people say they want to deliver. And therefore you induce, you get either the doctor to induce early, then you find, oh, that baby was too small. Yeah. So those are some of the risk factors.
Yeah. And
I
think
seems so wide, like pretty much anything.
Exactly.
Preterm, but go ahead, Dr. Emily.
Yeah, and I think one of the other key causes of preterm delivery, especially in our setting, is teenage pregnancies. And that's something that we are not talking about, as often as we should. In recent years, we are seeing lots and lots of adolescents who are giving birth before they should actually be pregnant. And of course, that has attendant risks. So that's something that we actually need to talk about as well. Yeah.
So, Patrick, when a mother comes, she's getting ready to deliver too early, too soon, usually on the other end, trying to make sure that things go right.
Sure.
That's not always the case, but in an emergency case, for instance, what is happening?
We need to start preparation of management of preterm labor, especially in the delivery room. Okay. So when we receive this mother in the delivery room, we need to at least try to stop the delivery from happening by use of drugs that stop the action of labor. We can also have use of antenatal corticosteroids. These are the drugs that will enable the lungs to mature, especially if this baby is going to come out. If the mother has had a premature rupture of membranes, we'll also need to treat so that we prevent ascending infection to the baby that we are going to deliver. Yeah. And then we anticipate for neonatal resuscitation. Remember, this is a baby who has come too soon. So this is a baby that we must be prepared to receive the baby. What is so special about these preterm deliveries, we actually don't try them immediately after delivery. After delivery, we cover them with plastic wraps. So we want to maintain the warmth. So imagine you have covered yourself with a plastic wrap and that sweat that you get. So we want that mechanism also to be used to maintain normothermia for these babies. And then we prepare these babies. If the baby requires neonatal resuscitation, we resuscitate the patient, stabilize before we transfer to the newborn unit for further management.
Right.
So in newborn unit, after we have received this baby, so we start care. Right. The care that we require for this baby is feeding. And actually, we are targeting feeding within the first 1 hour after delivery. And what is the challenge is that what might have caused this baby to be born too soon might be the condition that has affected the mother. And we find the challenge of providing breast milk within that first 1 hour after delivery. And actually the mainstay, the food or the feed that we want to feed this baby is the breast milk. So we still find a challenge there. But we are advocating within the first 1 hour, this baby should get that breast milk. It is actually therapeutic, it has nutritional value, it is also has, it also has components that will help prevent infections for the baby as well. Yeah. Feeding the baby, we also want to prevent infections for this baby. So hand hygiene is very important. And actually that is what we tell our mothers. Our mothers are our partners in care for this patient. And we also inform our healthcare workers on hand hygiene as well. We also want to prevent and treat the cases that these babies will have. We have cases of jaundice. Jaundice is the yellow discoloration of the skin, and actually normally comes because of prematurity. There is actual, the red blood cell breaking down is actually accelerated in premature babies. We also want to treat the breathing difficulties for these babies. So these babies actually present with respiratory distress syndrome because of the fact that their surfactant level actually is reduced. So how do you do so? So to ensure that there is surfactant production, we initiate these babies on CPAP. And CPAP is continuous positive airway pressure. So this one will help provide distending pressure to the lungs and as well maintaining the alveolus open, and also helps in production of this surfactant, the component that you want these lungs to always remain open. So when we advocate that all babies born preterm, we have prophylactic CPAP. So it will help in maintaining that breathing and also production of that surfactant as well. If that is so, if the baby is well and is breathing well, we also need to support their oxygenation. So we can use oxygen if the baby has no signs of difficulty in breathing. So we can support oxygen and monitor the oxygen levels as well. We remember oxygen is a drug and it is very toxic, especially for these preterm babies.
Absolutely.
Yes.
And I want to kind of stick on to that thread of response. Because what Patrick has just described is the ideal. But that's not the reality on the ground for a lot of healthcare facilities in this country. We saw the story in Garissa, their first oxygen plant in how many years?
Right.
So, you know, Dr. Kigondu, when you look at that and the gap, how do we begin to fill that so more babies can survive?
Yeah, so as we started the program, I said prevention is the best way to ensure that these babies survive. So the first thing is that the obstetrician and gynecologists and people in maternity, what kills the baby? Lung problems. So there's an injection called a corticosteroid that if a mother goes into preterm labor, then you can give the injection. It'll help develop the lungs. What he was calling surfactant, it develops. Because when the baby comes out and can't breathe, they will die. There is the brain. So when the brain is small, if people start preterm labor, then we can give a drug called magnesium sulfate. That goes to stabilize the brain. And this you give to the mother before the delivery so that it starts working there. Then we now need to do all other preventive measures, such as treating the maternal disorders that would cause preterm delivery, all those diseases and all. There's some medicine that is used when you have preeclampsia or hypertension in pregnancy to prevent this preterm, because a lot of the interventions for delivery of a preterm will be because the mother maybe has hypertension, so you can use junior aspirin and all. We also need to educate our mothers to avoid tobacco and alcohol. The weight, both underweight and overweight, we need to manage it. And we are seeing a lot of what is called in vitro fertilization. Therefore, we need policies to prevent you from putting too many, to prevent multiple pregnancies. And also, we need to prevent this, what is called cervical incompetence, by one, having good delivery, because, you know, you can tear the cervix during one delivery, then in subsequent pregnancies, you have incompetent cervix. So then we also need to see the doctors so that they can identify anything that might cause preterm delivery. It's good to go for antenatal care early.
You know, Dr. Emily, so how do we scale? Because, you know, we just saw in Pumwani, that's the only breast milk bank in the country.
Right.
We've seen at least the intervention in Garissa.
Right.
But a drop in the ocean.
Right. I think let me start by saying that milk sharing has happened for many years, even before we discovered human milk banking in this continent. We've had our aunties and grandmothers, you know, doing wet nursing in the villages because that's all we knew. We knew that breast milk was actually saving babies, and that's what we focused on. Yeah. And so this is not something that's new. Milk bank is not a concept that, you know, has been brought, you know, in recent years. It's something that has been happening and is actually currently happening even in the informal sector. If you think about the cost of formula, it's way out of reach for most of us. And so what is happening in the informal sector is that people are actually sharing milk and breastfeeding each other's babies. You know, which is very dangerous because
right.
we have so many, exactly, this milk is not screened. And so there's a very high risk of, you know, transmission of diseases. And so that's where human milk banking comes in. So human milk banking in itself is setting up standardized way of ensuring that we entrench this milk sharing in a way that is controlled, in a way that we can ensure that we screen this milk and ensure that there's no transmission of diseases. Recently, last year, in November of 2022, the WHO actually released guidelines on feeding of preterm and low birth weight babies. And part of those recommendations actually were that in case mom does not have enough milk, which is commonplace with preterm deliveries, the second best option is actually donor human milk, and that's from WHO. And that speaks to the need for actually scaling up human milk banking. And the other reason is because formula is actually not well digested by preterms. And one of the complications that they can get from feeding on formula is that they can get digestive infections, some of which can be fatal. And so preterms tend to not digest formula well. And so what are we saying? We are saying that we know that breastfeeding is best. We know that breastfeeding is what saves babies. Why are we not encouraging it? And in Kenya, let me just say that we have not done too well as we should. Looking at the Kenya Demographic Health Survey of 2022, we are seeing that our rates of exclusive breastfeeding up to 6 months have actually reduced to 60%. We were much higher than that. Our rates of starting breastfeeding within 1 hour of delivery has actually also reduced. So there's a gap. We actually need to be truthful and, you know, realize that newborn nutrition is, you know, we know it's an intervention that saves babies, but why are we not putting enough attention to it?
I have to ask this because even if you have and see the preterm babies survive, they grow up with complications.
Right.
What are those?
Yeah. So when we think about the effects of prematurity, a lot of us tend to, you know, just focus on the baby. Yeah. We know that babies delivered and, you know, their organs tend to be immature. And so they'll have difficulties in breathing because their lungs are immature. They'll have problems with their eyes. Some of them, unfortunately, end up blind or deaf long term. But more so, they also have other conditions such as rickets, which is malformation of the bones, because they just cannot metabolize some of these compounds. And they also have something called anemia, which is a low blood level. It's something that happens very commonly in preterm babies. And so these are complications that can be avoided if a baby is not born preterm. But beyond that, beyond the baby, we forget the mother, we forget the family. Because this mom really struggles with this baby. Remember, this is a very small baby, very fragile, and so it's a very scary time for the mom. And we forget that mom also suffers, you know, some form of effect to her mental health, and same goes to the father. And additionally, these families actually face stigma, and it's something that we're not talking about because we're just focusing on the baby. And the other thing that we forget to talk about is the financial burden to the family. Because care for preterms is very expensive. Most of these families end up spending quite a bit on the care of these preterms, and really also the man hours spent trying to, you know, come to the hospital to visit this baby. And this baby can stay in the ward for 2 months, 2 weeks, and several months in the hospital before they become well. And this is a challenge for families. Additionally, even beyond the family into the health system, preterm deliveries have a huge impact. Remember, I talked about the long-term complications with vision, with walking, with low blood levels. These children tend to need, long-term care within the health system. And so if we're saying that preterm delivery is actually preventable, then we're actually straining the health system unnecessarily. So we have thousands and thousands, even millions of babies who are going through the health system, seeking care, utilizing the resources within the health system, yet it could have been prevented. Yeah, so those are generally the effects that we see with prematurity.
Unfortunately, we've run out of time. I was going to ask Patrick really quickly in 30 seconds or less. If you had a wish list of what a nurse needs when a preterm baby is born, what would it be?
So the first thing that I'll have is a well-equipped newborn unit in terms of machines and technology. Also staffing, the staffing needs for these babies. We have the world WHO ratios for staffing. So actually we achieve that, and also trained staffs. If we achieve that, I think we'll be able to reduce neonatal mortality.
Thank you so much, Dr. Kigondu, Dr. Emily, Patrick, for your time. I wish we had more, but this is certainly the beginning of a more informative, incisive discussion that we need to have to see action on the ground, to save more babies. That is the end goal. Thank you so much. Let's take a short break here on Citizen Weekend. Sports news is coming up next. Stay with us.